My name is David Kuter. I'm Distinguished Physician at the Massachusetts General Hospital and Professor of Medicine at Harvard Medical School. I'm pleased to participate in the Autoimmune Hemolytic Anemia Awareness Day 2026. And my goal today is to talk to you about what is autoimmune hemolytic anemia and why do I as a patient have it. I have many different conflicts of interest in this presentation in that I work with many different groups to develop new therapies for this disease and many others. They're described here. My goal today is to talk to you as a patient and not as a physician or medical group about this disease. I'm going to describe red blood cells and their hemolysis. I'll describe the diagnostic criteria and clinical findings in this disease state. I'll discuss what's happening to me as a patient with autoimmune hemolytic anemia. I'll focus on warm autoimmune hemolysis and cold autoimmune hemolysis, and I'll try to help you understand why these disorders develop. I'll briefly mention treatment options, but I'm not going to focus on those. We'll have to save those for some other time. Now, the history of autoimmune hemolysis is quite long. It dates back to 1871 when a pair of physicians described exaggerated destruction of red cells leading to jaundice, which is the yellow color of your skin, and abnormal red cells, and they called this microcythemia. A very famous pathologist named Stephen Mackenzie in 1878 described black urine that was full of hemoglobin and felt that the kidneys were destroying red cells. In 1890, another chap named Wilson described red cell destruction in the spleen and called this chronic splenic cachexia. The famous transfusion medicine, Dr. Hayem, distinguished congenital from inherited hemolytic anemias and is the first to describe acquired hemolysis, which he called infectious splenomegalich icterus. And then finally, the challenge and the great advance was by Jonathan Landsteiner, who described a serum substance, which you now know to be antibodies, that cause red cell destructions. So let's begin about how hemolytic anemia happens, and many of you have these symptoms. I'll simply say that many patients lack symptoms, particularly if you have mild disease or it's well compensated. The symptoms of anemia in general are fatigue, syncope, shortness of breath, and pallor. The things that are specific for hemolysis or red cell destruction are jaundice, an enlarged spleen, which may not be terribly big, acrocyanosis or discoloration of your fingertips, and gallstones, which interestingly enough are usually pigmented like the color of a dark cherry liquid. The causes of anemia are many, and you know them all. They can be blood loss from bleeding too much. They can be bone marrow production issues due to things such as a bone marrow disease such as leukemia, or deficiencies in erythropoietin, which is a hormone regulating red cell production, or deficiencies of B12, folate, or iron. They can be due to other causes of red cell hemolysis. They can be non-immune, such as heart valves and a thrombotic disorder. And then we'll come to the diseases we'll talk about today, in which many of you may have, called warm autoimmune hemolytic anemia or cold autoimmune hemolysis. When one sees a patient, such as many of you, for anemia, we think about history, we think about symptoms. Are you chewing a lot of clay or ice, which is called pica, indicating iron deficiency? How long has this been going on? Has there been a prior bout of anemia? Has there been bleeding or heavy menstrual periods? Are there medications involved? Are there other medical problems such as ulcers or dyspepsia? Are there nutritional problems? Have you had a colonoscopy or an examination of your upper stomach? The physical exam, which helps us a lot, is the skin color. Are you pale or not? Are your conjunctiva pale? Is there lymph nodes that are enlarged called adenopathy? Is your spleen enlarged? Are there nail changes? Is there blood in your stool? These are all general aspects of the evaluation for anemia. The general tests for anemia you're all familiar with. They're a blood count called a CBC and differential. A reticulocyte count measures the new red cells being made. Your physician should always look at your blood under the microscope to assess what else might be going on. There are a lot of nice, clever clues to hemolysis by looking at the blood smear. One checks the iron, total binding capacity, and ferritin. B12 and folate should be checked in everybody. The signs of hemolysis will come toward the LDH and haptoglobin. I'll describe in a few minutes what those mean. And we also check inflammatory markers called the SED rate or the C-reactive protein. Serum electrophoresis may be helpful in some patients because you may be concerned about other underlying blood conditions, but we'll talk about those at a later date. Now, when do you think about hemolysis as a cause of anemia? Well, you think about it when there's no clear blood loss, when there may be no clear nutritional deficiency, where the reticulocyte count or LDH are elevated, or there's a depressed test called the haptoglobin, or there's sudden onset of anemia. We worry about new medications. We measure and assess for other autoimmune conditions such as lupus. We look for a history of ITP, which is destruction of platelets. We look for changes in your fingers and hands, nose, and ears, acrocyanosis, which I'll show you pictures of in a few minutes. We look for the signs of jaundice, which indicate red cell destruction. This is also called icterus. Now, how do we think about how hemolysis occurs? This is called pathophysiology. It just means what's the explanation for why red cells get hemolyzed. And this is the normal red cell lifespan. We make red cells in our bone marrow. They stay here for a couple days. They become newly formed red cells called reticulocytes. These are staying in your bone marrow for a while. They then enter your circulation, stay there for a day, and then the red cell lives for normally about 120 days before it dies. When red cells die, the contents of the red cell release an enzyme called LDH, which can be measured at low levels in normal people. The red part of the red cell called hemoglobin contains many things. It contains iron, which if it's released into the circulation is cast into your kidneys, and there's a substance called urine hemosiderin that we can detect. If too much get released into your blood, it binds to a protein called haptoglobin and makes us low, and then the heme port of it, the iron port of it, gets metabolized to a thing called bilirubin, which makes you jaundice. So in normal red cell destruction, this happens at a low, steady rate. About 1% of your blood cells turn over every day or two, and these levels are very low. If you have increased hemolytic anemia or destruction, and this is the definition of hemolytic anemia, meaning red cell survival is less than 100 days. Normal red cells live for 120 days. We normally turn over or destroy 1% of our red cells per day. We can maximally do this without affecting our blood counts too much by 5%. We can compensate very well for even an increase of 5% of our red cells being turned over every day. There's a thing called Gilbert's phenomenon, which is a thing that makes the bilirubin rise faster than normal. About anywhere from 5 to 30% of Caucasian adults have this metabolic derangement. It's not a bad problem, but it happens in a lot of people who are Caucasian. The bilirubin, or the pigment that you can see as yellowness in the eyes, may be elevated just normally in these patients, and it gets enormously exacerbated if you also have hemolysis on top of that. We have many compensatory mechanisms in our body that let us make more red cells. The hormone erythropoietin increases blood production, and normal red cell production can increase 5 to 8-fold in response to any destructive event. So these are the things we think about when someone now starts having hemolysis. And so if we return to our diagram, if you're now hemolyzing red cells at a large rate, if you decide to destroy a lot of red cells for many reasons, what happens here is your bone marrow gets revved up. It makes more red cell precursors. They make more of these interesting new red cells called reticulocytes, and there are more of these in our circulation. As I said, if you have a problem with red cell destruction or hemolysis, the red cells shown here get destroyed at a faster rate. And when they get destroyed, they may release into the circulation this substance in all blood cells and all cells in general called LDH. This is an enzyme, and this will rise in many patients who have red cell destruction. When the red cells are destroyed, they get removed from your body, and the hemoglobin, the pigment, if it's present and released into the circulation, will be filtered by the kidney, and you can do a kidney test looking for a substance called hemosiderin in the urine. This is an ancient test which is not commonly done. More commonly, we looked for whether the hemoglobin, if it's released in the circulation, binds to a protein, a substance in the blood called haptoglobin. When hemoglobin binds to haptoglobin, the levels of haptoglobin decline, and they indicate that you've released hemoglobin to the circulation. Finally, when you have increased red cell destruction, the hemoglobin has to go somewhere. It gets destroyed by our body, and the pigment in it, which is the heme molecule containing iron, gets converted to a substance called bilirubin, which can make your eyes and your skin and your urine dark, which is called icterus or jaundice. So in patients who have increased red cell destruction called hemolysis, a lot of things happen. So the clinical indicators of hemolysis are an increased LDH, a reduced haptoglobin, an increased bilirubin, particularly in the Caucasian patients who have this thing called Gilbert's phenomenon, and that's why this condition is picked up much more commonly in this class of patients. The number of new red cells called reticulocytes may increase, and in patients who destroy blood, particularly if it's destroyed inside your blood vessel and not outside your blood vessel, such in the spleen, we can see increases in this thing called hemosiderin, which is a urine test, and we can also measure in your urine or serum free hemoglobin. This happens when we have what's called intravascular hemolysis. Most of you who have cold or warm antibody disease, most of your hemolysis is extravascular, meaning it doesn't happen a lot inside your bloodstream. So these things indicate the extent to which red cells are being destroyed inside your circulation and not outside your circulation, organs such as the spleen. There are many exceptions to these rules. The thing called the reticulocyte count may be low in patients who are destroying red cells. And this happens a third of the time because the red cells, the new red cells called reticulocytes, are also being destroyed. Patients who have other blood conditions, such as a nutritional deficiency, such as iron or folate deficiency, may not make a lot of good red cells to compensate for those that are being destroyed. And finally, and this is very common, you can destroy an enormous amount of red cells without becoming anemic. We have about a 5-fold increased capacity to make new red cells to compensate for those which are being destroyed. So in general, and this is going to be the set of 3 definitions I'll give you, hemolysis from all causes by definition is anemia with a shortened red cell survival, and this is diagnosed in general by a LDH which is greater than the upper limits of normal, meaning an increased LDH, and a haptoglobin which is below the lower limits of normal, meaning it's depressed. So these are the 2 findings, the 2 characteristics which are commonly used to define whether someone is hemolyzing or not. They're not perfect tests, but they're commonly used. So if your doctors say to you your LDH is high, you can think about my red cells are being destroyed too fast. If they say my haptoglobin is too low, then you think about the fact that you're also destroying red cells too fast. And the haptoglobin is an incredibly sensitive indicator of hemolysis. You need to only hemolyze 5 or 10 milliliters of blood inside of yourself to have this test become negative. So hemolysis is a very common medical problem. Some of you have other hemolytic disorders, but there are some that are what are called intrinsic, meaning they're defects of the red cell itself. These are things that alter the membrane of the red cell. An example is a thing called hereditary spherocytosis. Some patients have enzyme defects which are very rare, such as pyruvate kinase deficiency, or a very common defect called G6PD deficiency, which affects up to 500 million people in the world. Others can have defects in hemoglobin, such as the common disease sickle cell disease or thalassemia. These are disorders that are due to the red cell being defective in itself. Other forms of hemolysis are what we consider extrinsic. The red cells are normal, but something else causes them to be destroyed. Now, there are non-immune causes of red cell destruction, such as artificial heart valves, clotting diseases, infections such as malaria and babesiosis. There's oxidative stress, such as medications. There's liver failure. There's patients who have big spleens and chew up spleens. These are all disorders I'll not talk about. We're going to focus on the tip of the iceberg, which are the immune disorders, which are called autoimmune hemolytic anemias, and they come in 2 general classes, one due to a cold antibody, which is called cold agglutinin disease or cold agglutinin syndrome, or a warm antibody called warm autoimmune hemolytic anemia. There are rare patients, maybe 5% of the total, that have both of these at the same time, we're not going to talk about this very complicated situation. We'll try to make this as simple as we can. And I'm going to also emphasize two terms, intravascular and extravascular. Intravascular means much of the red cell destruction is occurring inside your blood vessel. And we think about extravascular means happening outside your blood vessel in organs such as the liver and spleen, or the red cells are being sequestered, destroyed. Now, the tests in hemolysis and autoimmune hemolysis are interesting and archaic. This is our dear friend, someone I knew well many years ago, Robin Coombs, who invented a test named the Coombs test. Many of you have had this test done on you to diagnose your autoimmune hemolysis. And what Robin showed many years ago is if here's a red cell here, and these are antibodies stuck on the surface, this is the cause of your hemolysis. If you want to say, do red cells have antibody on the surface, you can make a special reagent, which is also an antibody, but this antibody targets other antibodies. So this is an antibody which is used to detect other antibodies on the surface of red cells. If you have excess antibodies on the surface of your red cells, by adding this reagent, you cause your red cells to clump. And this is called a positive Coombs test or direct antiglobulin test. It says there are antibodies or complement on the surface of your blood cell. Now, what you can do is take the red cells and sort of shake off the antibodies and collect them separate from the red cells, and take these antibodies from your own abnormal blood cells, which are coated with them, and then add them to other target red cells in the blood bank. And this is to identify whether the antibodies from your red cells bind to other red cells. If they do, you can then add this reagent called the Coombs reagent, which again is an antibody detecting other antibodies or complement, and see if this is called the eluate. This is the antibodies that are taken off your red cells. You can see if your eluate binds to a whole panel of red cells. And this gives us what's called the indirect Coombs test, or the eluate. And these two tests are commonly used in laboratories to assess you for your type of hemolysis. And so I'll give you an example, and I'm not going to make this too arcane, but I'm just going to tell you these are tests that you've probably seen in your record. If your red cells are coated with IgG and the eluate binds all other kinds of red cells, this helps diagnose a warm autoimmune hemolytic anemia. If your red cells only bind this substance I'll talk about in a second called complement, that goes along with this being cold agglutinin disease or other diseases. There are nuances in between I'm not going to go into it. Basically, a positive Coombs test or direct antiglobulin test helps guide us in diagnosing the type of autoimmune hemolysis that any patient has. So this is my second set of definitions. My first definition was defining hemolysis. My second definition is what defines an autoimmune hemolytic anemia. By definition, it shows evidence of hemolysis. It has a positive Coombs test, and as I'll show you momentarily, has a characteristic blood smear under the microscope. These are the way one diagnoses autoimmune hemolytic anemias, and all of you who have these diseases have had these tests done at some stage or the other. So let's switch gears and talk about the first type of autoimmune hemolytic anemia. We have two different types of hemolysis. We have the warm autoimmune hemolytic anemia. This is 80% of autoimmune hemolysis. Is what's called a warm antibody. It means it reacts at anywhere from room temperature to body temperature. This is a type of antibody called an IgG antibody that reacts with substances on red cells called proteins. These are also called antigens on the red cell surface, and this occurs at core body temperature. Now, some of you may have a cold antibody. This is a different kind of antibody called IgM antibody that has an interesting property. It only reacts to sugars on the surface of red cells when the temperature is low. And this is called a cold agglutinin. And as I'll describe momentarily, there are two types of cold antibody diseases. One is called cold agglutinin disease, and one is called cold agglutinin syndrome. And I'll distinguish these momentarily. So think about the types of autoimmune hemolysis as being a warm antibody, reacts at body temperature, and there's a cold antibody reacting at below the core body temperature. One is an IgG usually, and this is usually IgM. That's as much of the basic science I want to give you, but without confusing us. But many of you have heard these terms when your doctors have talked to you about it. So what is warm autoimmune hemolytic anemia? This is a disease. It happens with increasing frequencies as you get older. So as you get older, your incidence of warm antibody hemolysis rises. Your incidence of cold autoimmune hemolysis rises. It can still happen in younger populations, but like many things in life, the older you get, the more things don't work as well as you'd like them to work. Now let's talk about warm antibody hemolysis. There's an antibody and there's an antigen. These are the actors in the play. The antibodies, as shown here, are IgG. Polyclonal means they are of many different types. They sometimes fix a thing called complement. And just to make life easier for all of us in this discourse, complement is something that binds to antibodies when the antibodies have bound to something else. And this is the way the body amplifies the immune response to make you destroy things that you want to destroy, like bacteria. But in this case, it's destroying your red cells, something you don't want to do. So complement amplifies the antibodies, both for IgG, warm antibody, and as I'll describe in a minute, also for cold antibodies. And these antibodies are temperature independent. This is the actor. The antigens, what do they react against? They are proteins on red cell surfaces. They have different names. You may recall the Rh protein, if you've heard about Rh differences that many mothers may have for their kids. They're also called glycophorin. And to give you a picture, this is the surface of a red cell. It's got this lovely thing called an Rh protein, and it's got a whole bunch of these squiggly things here called glycophorin A, B, C, and D. And when I explain this to my mother, she says these are like snakes on the red cell membrane. But these are things that are on our red cells, and we can make antibodies against these or against these. And if you remember how the COVID virus has spikes on the virus surface, these are like those spikes on the COVID virus surface. And like you make antibodies to COVID, you can make antibodies to these surface moieties on the red cell. And so warm antibody hemolysis in terms of we use this word pathophysiology, it just means how this is happening. Here's a red cell. You've now made an antibody to it. The antibody coats the red cell, and what happens is it may go to your spleen where it's massaged into a funny looking red cell called a spherocyte. I'll describe this momentarily. Sometimes the spleen simply destroys the red cells. In the spleen, this again is called extravascular hemolysis. Occasionally, the warm antibody has, and this happens in 20% of patients, has this stuff called complement added to it, and this makes the red cell even more aggressively destroyed. Sometimes when complement binds to red cells, it results in the red cell being destroyed inside your bloodstream. This happens rather uncommonly in warm antibody disease, but if complement's bound to the red cell, it's now cleared by the liver, a process called extravascular hemolysis, and there are special cells in the liver that destroy these red cells. So it is the simplest approach to warm antibody hemolysis. It's all happening in the spleen. The more complicated story is if you have complement, there may be additional destruction in the liver, and in a very, very rare patient, it may all happen inside your circulation. But this is the underlying disease state happening if you have a warm antibody disorder. Now, I said you have spherocytes. Now, what is a spherocyte? Here's a normal red cell. It's like a donut. It's got a hole in the middle. A spherocyte is a cell like this where the hole disappears. What's happened is this normal red cell here has had its membrane stripped away, and as the red cell membrane becomes less, the concentration of hemoglobin rises in it. So this red cell here has as much hemoglobin as this one did, but it's in a smaller shape, which is much more deformable. Now, this is where I'm going to, if I could do this in person, I'd ask a quiz, and I'd say, well, how many of you had your spleens taken out, and how do you know? You know if you have your spleen taken out because this lovely little dot occurs here, and this is called a Howell-Jolly body. This indicates the spleen has been taken out, and this is a patient with warm antibody disease who has not had good outcomes from the splenectomy. Now, we talk a lot about the spleen. This is a nifty organ that we all have, or if you have had it taken out, you don't have this, but blood flows in by the arteries. and it then sort of diffuses inside this very large, soft organ, and then the blood's got to flow back into the veins here and get back to your heart. So blood flows in here, it gets then sent into the sponge-like area of the spleen, and then it's got to find its way back into the circulation here. And what's interesting is here's the inside of the spleen. This is the sponge, and here's a red cell which has been put into the sponge. It's now got to get back into the circulation and get into the vein here. It's got to go through this very interesting mechanism, like a screen. In order to get through the screen, it's got to pass through these small holes. And if the red cell is now a spherocyte and not deformable, it gets trapped here and destroyed by the spleen. This is how spherocytes are made. It's also how they're destroyed in your body. And this is another picture of this. This is another picture from the inside of the blood vessel of this very funny lining of the blood vessels. And you can imagine a red cell having troubles trying to sneak through this hole between these guard gates here. So coming to another definition, warm autoimmune hemolysis by definition, evidence of hemolysis, an IgG antibody that binds to proteins. This is the Coombs test I mentioned to you a few minutes ago. About a third of the patients have both IgG and complement, and maybe 5% of people are called Coombs negative, meaning the test is negative. That's a topic for some other time. So we need hemolysis, we need a Coombs test, and we need a characteristic blood smear that your doctor should look at. And I hope your doctors have showed you pictures of your blood to let you know what's going on here. Now, what causes warm autoimmune hemolytic anemia? Unfortunately, about a little under half are idiopathic, when you have no idea why it's happening. Some patients have an underlying pretty mild, what's called lymphoproliferative disease, also called a lymphoma. This is about a quarter of all patients. Very common in patients who have a reasonably benign leukemia called chronic lymphocytic leukemia. About 25% of patients have other autoimmune disorders, such as a thing called common variable immune deficiency, or the autoimmune disorder lupus or ulcerative colitis. It's also common in patients with ITP who have both ITP, destruction of platelets, and destruction of red cells, called Evans syndrome. And there's a wide variety of other things here which are less common. These don't usually give chronic disease. Viral infections and drugs can cause lots of hemolysis. This is usually transient. So we're going to talk about the things that cause chronic warm antibody hemolysis. It's usually immune disorders, lymphoproliferative diseases, or we don't know. Now, I'm not going to talk about how one treats warm autoimmune hemolytic anemia. Each of these topics is a discussion itself, and my goal here is to give you an overview of a disease which many of you have. I will simply say that the treatment of warm autoimmune hemolysis varies enormously, from red cell transfusions to providing nutritional support with adequate folate, B12, and iron. And I would hope that all of you who are hemolyzing are on at least folic acid every day. We may try to reduce the antibody which is causing this by corticosteroids, the miracle drug rituximab, other agents such as mycophenolate or azathioprine, or the immunosuppressive drugs sirolimus, Cytoxan, or cyclosporin. Other drugs such as danazol, daratumumab, alemtuzumab these are major immune suppression drugs. This is a attenuated androgen that is used sometimes to treat this disease. These are many therapies that try to target the antibody production. If you want to destroy where the red cells are being destroyed, this is the spleen and the liver is where the red cells are destroyed by a special cell called a macrophage. We can give you steroids. We can take out your spleen. This has got a high response rate. Some patients do well with IVIG or the drug vincristine. And sometimes we give patients erythropoietin. This is a short list of current therapies. What I'm not showing here is an expanded list of newer therapies under development, and we'll have to save that discussion for some other time. So the way one treats warm autoimmune hemolytic anemia, at least in our hospital, is we give you corticosteroids, unfortunately, for usually a short time, hopefully under 3 or 4 weeks. We add rituximab early if you're having troubles. We add rituximab a little later on if the steroids don't solve the problem. If you don't respond well to rituximab or not as well as we'd like, we add immunosuppressive agents such as a drug CellCept or mycophenolate, sometimes sirolimus. We will then, if this doesn't work, add an erythropoietin agent, which is a hormone that stimulates red cell production. If you fail these, we have a whole bunch of new agents for warm antibody hemolysis, which I will have to describe in some other lecture at some other time. We do clinical trials, and we rarely do splenectomy, but splenectomy still is an option that one has to address in this disease state. Again, a topic for some other time. So let's shift gears to those of you that have cold autoimmune hemolytic anemia. It has two general names. One is called cold agglutinin disease, or CAD, and the other is called cold agglutinin syndrome, or CAS. I'll describe these separately in a few minutes. So what are the actors in this play? Well, the antibody is different. The antibody is called an IgM antibody, a different kind of antibody. This is a very weak antibody that binds very weakly to red cells, which is why it binds only well when the red cells are cold. It's got what's called a thermal amplitude, meaning it binds much better at 4 degrees than at body temperature. This is a funny kind of antibody. It very nicely binds a substance called complement. So when you have IgM sticking to red cells, it fixes tons of this stuff called complement, which enhances destruction of red cells. So this is the antibody. The antigen, which is the thing it's acting on, is a sugar molecule which has variable concentrations on red cells. I'm not going to go into the nuances of the sugar molecule, but basically the antibody binds in a very weak fashion to the sugar moieties on the surface of red cells, and this is how the antibody binds to the red cell. So this is the cartoon model of what's going on here. Here are red cells, and the antibody called IgM can actually link two red cells together and give you a clump of red cells. It then fixes this yellow bar here called complement. And the complement then has more things added to it, which makes the red cell very appetizing to cells in your liver that will remove them from the circulation. So what happens in most people with cold agglutinin disease is the red cells become cold. They fix complement. When the red cells go back into your central circulation from your fingers, the antibody comes off, and the red cells are coated with complement, and they're directly destroyed in the liver in most situations, but they also can be destroyed in your circulation when more complement gets added to the red cell, and you can actually lyse some red cells inside your circulation. Again, this is called intravascular hemolysis. This is called extravascular hemolysis. Now, what happens in some red cells is they pass the gauntlet. They survive this, and they have the complement be metabolized to a non-active form, and this is what happens when red cells survive this process. And so these are some red cells which are left over that are spared the ravages of being destroyed. But basically the main thing going on in your body is this funny antibody binds when it's cold to red cells, complements added to the red cells. When the red cells become warm, when they go back from your fingers to your heart, the antibody comes off, the red cells are now coated with complement, and the complement either directs destruction in the liver or it directs some what's called intravascular destruction inside your circulation. Now, here's some pictures. This is the clumping of red cells that occur. This happens in all of you with cold agglutinin disease under the microscope. This is a very simple thing to look at with your doctors and helps define the disease. This is the normal tube of blood when it's 37 degrees. If you cool it down in an ice bucket, you see clumps of red cells. This is what's happening in the test tube, but also what's happening into you and your fingers and toes. And if it happens too badly, it can give you troubles with circulation in your fingers or even destruction of your fingertips. This is called acrocyanosis, which happens in about half of patients with cold autoimmune hemolytic anemia. So coming to my fourth definition, what is cold autoimmune hemolytic anemia? It's evidence of hemolysis like before. It's now the identification with this Coombs test of an IgM antibody, which we identify by a Coombs test that's positive only for the substance called complement, and by a characteristic blood smear, which I just showed you, with red cell aggregates, and probably also in about half the patients with this change in your fingertips, your ears, nose, and toes called acrocyanosis. What causes cold autoagglutinin disease or gluten disease? Sometimes it's due to infection. If it is an infection like mononucleosis, it's transient and it disappears. We're not going to talk about this. All of you who are attending this meeting are going to have either secondary chronic cold agglutinin syndrome due to a low-grade lymphoma, such as Waldenstrom's macroglobulinemia, or have a primary cold agglutinin disease called CAD. This also is due to a very low-grade proliferation of one type of B cells, but it's not considered a lymphoma. So this is a different kind of disease process than is the warm antibody disease. But basically, if you have cold agglutinins in your body, they're either due to a low-grade lymphoma, and we call it cold agglutinin syndrome, or you don't have a diagnosis of lymphoma, but still have some atypical or not normal, what are called lymphocytes. This is called cold agglutinin disease. So how do we treat this disorder? Well, again, the classic statement is avoid the cold, which is impossible to do even in Florida, since the stores are all air conditioned and we have cooling devices everywhere. We give patients folate and iron. We will give red cell transfusions, oftentimes with the use of a blood warmer. Sometimes plasmapheresis can be used. This is a blood procedure where we take off the antibody causing a disease. This is a transient benefit, but sometimes it works quite well. The hormone erythropoietin, as I mentioned to you before, can stimulate red cell production. There are chemotherapy agents which are low grade called cyclophosphamide or the old agent chlorambucil. We can try to be more aggressive in treating the underlying lymphocytes making this disease with rituximab, or rituximab with fludarabine or cladribine, or rituximab plus bendamustine, which is the standard therapy for many patients. We have a newer agent which our office helped to develop called sutimlimab, and there are many clinical trials I don't have the time to talk about, but these are the current therapies. And I always like to show a picture, which I don't advocate as a therapy. This is a patient back in the 1960s who had a suit belt where his body temperature was being maintained. This is my colleague Paul Ness walking around the campus at Hopkins, but this is a novel therapy for cold agglutinin. Just stay warm. It's awful impossible to do this, and you can't live like this, but this is a therapy that was developed many decades ago for treating this condition. So in terms of our treatment algorithm, and this is where I'm going to end our discussion in terms of treatment for this disease, if you have a diagnosis of cold agglutinin disease, we will use transfusion supportive care to get control of the disease initially. Steroids don't work very well. Some patients benefit from the drug sutimlimab, which is an infusion to control the disease until a appropriate therapy with rituximab or bendamustine and rituximab are given. There are other drugs that can be used in this therapy, such as bortezomib. If you fail at this level, we think about clinical trials, but many patients will have the hemolysis well taken care of by the drug sutimlimab, which is a topic for some other time. If you're not a candidate for chemotherapy, sutimlimab works very well in most patients with cold agglutinin disease by turning off the hemolysis, but unfortunately, it does not affect the acrocyanosis, which can be a dickens of a thing to take care of. So to summarize and end this overview, which I hope has helped you understand your disease better, in terms of having an autoimmune hemolysis, we first have to prove you have hemolysis, as I mentioned before, by looking at the LDH, haptoglobin, blood smear, reticulocyte count, and other indicators of hemolysis. So the first step in anyone is prove there's hemolysis. We then do a DAT, a direct antiglobulin test, also called a Coombs test, and look at the blood smear to help categorize this. If you have a warm autoimmune hemolytic anemia, this is caused by a IgG antibody. These patients do respond to steroids, rituximab, splenectomy occasionally, which I don't advocate. There are lots of novel therapies for this disease, which we'll talk about some other time, such as fostamatinib, FcRn inhibitors, or Bruton kinase inhibitors. If you have cold agglutinin hemolytic anemia, if you have typical CAD with no underlying lymphoma, a standard of care is rituximab or rituximab with bendamustine, or C1 inhibitors, this is sutimlimab. If you have cold agglutinin syndrome with an active lymphoma, such as Waldenstrom's, the current therapy is to treat the lymphoma. If that doesn't work, then we treat this like we do the CAD with rituximab and bendamustine, or the drug sutimlimab, or other molecules that inhibit complement activation. So I'll leave at this time and thank you for asking me to come talk to you today. I hope this talk gives you a brief overview of how your disease behaves. Thank you.